My name is Prof Clevert. It's great to have you here. And the first question is, do you have any experience regarding fusion?
Not at all.
Not at all.
Student in biomedical engineering.
Biomedical engineering. Oh, okay. That's not too bad. So then we go very in the deep how it's working. And of course, all the systems that you see here are often option that there is fusion available. Also, other vendors have got fusion. Nearly every vendor has got fusion. But we're focusing on this equipment here. So what options are available? Ultrasound. We have got grayscale. We can speak about strain imaging. We can use contrast. And we can also mix everything again with fusion. What fusion means is we can use data from MRI, CT, PET MRI, PET CT, and upload this data directly on the system. If we use contrast, this is an important part also in the fusion tool, there's a special contrast agent. So I'll give you a short introduction how this contrast looks like. You see this bubble is very, very small, like a single red blood cell, very, very small. The first generation of bubbles was filled with air, nowadays it's filled with gas. All bubble has got a shell, it's important. It's either a palmitin shell, albumin shell, or lipid shell. And the major difference in comparison to CT or MRI is that we are speaking about a pure blood pool contrast agent. This means if it stays in the vessel, the whole examination time, it only leaves the vessel if there will be an active bleeding. So you see a single bubble, the sound wave of the probe compress and decompress the bubble, and the bubble is working like a backscatter. So we received up to 30 dB of more signal. But you need a special software. If you don't have the software, you will burst it. If you have got the software, you see the oscillation of a single bubble. That's important. And if you try it without, you see this bubble will immediately burst. So you have no benefit, only cost. That's not good. All patients have to give an informed consent, so they should be agree that you're allowed to inject. Good news is these contrast agents have no influence on kidney or thyroid function. So you can just go forward and straight on, inject it if they agree. And the risk of having some side effects is only 1 in 10,000 cases, very, very low. So you see already here, we have got the MRI, we have got the CT. And of course, these are great, expensive systems, and they produce very nice images. So why don't combine the strengths of MRI or CT in your ultrasound system? You see already a CT and an ultrasound image on the screen, but I will show you how it's working. So first of all, you have to make a decision what kind of modality you would like to use. So if you go to a radiology department and you receive whatever MRI or CT, you get normally patient data like a CD or DVD. You can use this DVD and directly upload it on the system. You can also upload this data from the PACS to the system. Once the data is on the system, just have to think about which plane is which plane, and then you acquire, and then it works both by side. There's one small risk you have to think about it. We need a magnify generator to track the movement of the probe. This might be in interaction with a cardiac pacemaker. So patients with cardiac pacemaker are not the best patient to include. The good news is the generator is not so strong that your credit card will be deleted. But it has got a field around about 6 centimeters. So if you would like to do fusion of the abdomen and the pacemaker is here, if it's really need, you go up to the knee with the magnetic generator, then it's far away. Or you have to check the pacemaker after if everything is fine. There's a couple of options how to do fusion. So you can do point to point. You say this point in the CT is the same point in ultrasound, and you use a couple of points, and then the system do it automatically. or you can do auto-registration, so the system automatically detects the landmarks in ultrasound and compare to the landmark in CT and do the fusion. Or what I the most time prefer is I use plane registration. So I hold the plane in exactly the same plane as the CT or MRI acquire data, axial plane. And then I said to the system, oh, this plane is the same like the other plane, push a button, freeze, and then it's registered. So you see our magnified generator, then you see a sensor which is connected to the probe there. The new generation of probes, for example this probe here, there is a sensor already included. The older generation of the probes, like this, you have an external bracket where the sensor is connected. But of course, a sensor is needed. Then we have got also a patient tracker. Patient tracker means that you know exactly where is a patient in the room. So if the patient moves, the tracker moves, and the system know exactly, okay, we also have to move the images. Otherwise, if we do it without any patient tracker, patient move a little bit, your registration will not work anymore. And once you have done the registration, you see there's a control box. This control box is inside of the system. Normally on the back of the system, there's a printer here, there is a magnified generator, and the control box is inside. When you ask me how long is Fusion available, I can tell you quite a while. I have done my first personal experience with Fusion in the year 2005. This is nearly 20 years ago. At this time, calibration of the system took 3 hours for a single patient. 3 hours. This was for research and not for a lot of patients. But if you see these images over there, they're more than 20 years old. But you see registration, ultrasound and CT at this time even it works. We had no bracket for the probe. We used some glue and connected to the probe, the sensor. And we had also no patient tracker, so if the patient moves a little bit, we have to start from zero. But even if you look at this paper, which was published 2006 and 2007, from the data from 2005, it works pretty good. Now, I would like to share you a couple of cases where we can discuss the advantage. So you see this is a young woman. This patient has suspicion of an FNH in the MRI, but due to the fact that this lesion compressed the gallbladder, ultrasound was recommended. The problem with ultrasound is it's very personalized. So sometimes you have got a problem to say, are you sure that you really cover the correct lesion or where are you? But if you use a fusion tool, you get the landmarks from CT directly side by side. So you see the MRI. I show you some landmarks. So you see the gallbladder here. And you see this lesion here compress the wall of the gallbladder. That's the reason why they said probably FNH, but due to the fact that it compressed the gallbladder wall, please check it with ultrasound. So you see, we have done already registration. So you see on the one side the grayscale with MRI, on the other side the color Doppler with MRI. So you can match it with grayscale, color Doppler, contrast. And you already see, look, here is the gallbladder in ultrasound. There's the gallbladder in MRI. There's the lesion. You see very nice how this lesion compressed the gallbladder wall. And you see there the feeding vessel. The question is, what kind of lesion this might be? Of course, we would like to prove whether our registration is fine. So we just have to turn a button and then it can switch from ultrasound to MRI and backwards because it's an overlaying. So you see, I just turn the knob and you see the border of the lesion in grayscale has the same border or similar border like the lesion in the MRI. So registration works. Now you can do this either with grayscale and also with color Doppler. You still see there is some vessels here, and maybe this is also the key question, is this a feeding vessel or what it is? In the next step, we go to the contrast mode. So we start with contrast, and you see immediately this lesion show a very, very strong uptake. Look at this torsion of the feeding vessel here. If you see this pattern, you know exactly, in the most time it's an FNH. And a little bit later, you see also very nice. Look here at this area. You see a drainage vein there. Very slowly. This lesion shows strong uptake from the center to the peripheral. And due to the fact that this lesion has no washout later, we know exactly, we could confirm the diagnosis of the MRI. It's just an FNH. Sometimes even benign lesion could compress something, but there is no risk of cancer in this case. Okay, now I have a couple of cases, and you have to think about, is this an FNH, is it a hemangioma, is it an HTC or liver mets? So it will be more interactive. Probably you will say, yes, it is an FNH, because I already told you the story. But you know, there will be a couple other cases where it is not so easy, so you understand the game, the rules. Okay. This is a 51-year-old patient. This patient has got colorectal cancer in June of 2015. This patient underwent surgery. There was an unclear lesion detected in CT a half year later, 2016. Then they come back to ultrasound, and we should tell them what kind of lesion it is. Is it a mass or maybe something else? So you see side by side the CT and the ultrasound. There is an option that you can use tracker or landmarks on the ultrasound. You mark it, or on CT you mark it, and this marker will transfer to the grayscale image. You see there's a blue circle here. If you are very close to your lesion, the circle is smaller. If you are far away, it's getting bigger. So we speak about this tiny lesion here. This lesion is maybe 7-8 millimeter, very small. But you also see there is a lesion in the grayscale. Look here. There's a lesion. This lesion doesn't have major vessels. Okay. In the next step, we switch to the contrast mode and we repeat it. You see, if the patient breathes, there will be a little bit movement of the CT data. And you see very nice here, this lesion has got a complete different behavior like the lesion you have seen before. Remember, the other was like a flashlight, very strong uptake. And here you have got a perinodal enhancement. And what happens over time? You see more and more contrast show up in this lesion. So if you have less experience with contrast, we make it very easy. Every lesion which have got an uptake and still have contrast at the end of the examination is a benign. Every lesion which have got an uptake and a washout, the late phase is a malignant lesion. So make it easier for you. So we look later. This is after around about 1.2 or 1.5 minutes. You still see it's completely filled with contrast. there are different settings available, so it must not be side by side. You can have either a big image or like these kind of 4 images, or 1 big and 3 small. So whatever you prefer is available. And this is also, you see, where I hold the probe for doing this examination. Now, of course, you are a bioengineer student, oh, correct?
Yeah, biomedical.
Biomedical. So you have less experience regarding pathologies, oh?
Yeah.
Okay. So the question is there still contrast in this lesion or not?
No. Yes.
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 So it is a benign lesion.
Yeah.
Yeah. So you can exclude HCC liver mets. There was already contrast in. A cyst have no blood supply, or? So you could exclude cyst. Now only 2 answers available, FNH and hemangioma. Does this lesion have the same behavior like the first you have seen?
No.
So it could not be an FNH.
So it
Must be hemangioma. Now we have to prove whether it's the correct answer. Yeah, you got it. This very fast. You see very nice this perinodal enhancement. You see exactly where to look. And you see over time that this lesion is filled with contrast. So, correct answer. Another patient. This patient had got breast cancer in the past. The patient underwent staging, CT staging of the abdomen, and the follow-up ultrasound examination was recommended. So you see the CT and you see the ultrasound. Grayscale, color Doppler. We mark this lesion with a landmark, and this landmark is transferred also to the ultrasound image. So we know exactly where to look at the grayscale. Okay, probably you will agree that there's a lesion, or where the blue circle is. This lesion has got a diameter round about maybe 2 centimeters, yeah, or even less. So from this point to the other point is 1 centimeter, so 1.5 centimeters, small one. Okay. I just use different layouts, so you see, I prove if I turn the knob, is the plane fine or not. So we see the border of the CT liver looks very similar like the border of the ultrasound liver. So our registration is fine. In the next step, we have to think about what kind of lesions might be. So we see our blue circle there. So this is the area of interest because we have to see how does this lesion behave. Okay, we see a moderated uptake, a little stronger in comparison to the surrounding tissue. But you also see already at the end of this clip that this lesion gets darker in the middle. You see this there? Okay. Side by side, washout. Okay, so we see there's a lesion. This lesion has got an atypical contrast behavior in comparison to the rest of the liver. And now we have to make a decision. Is this an FNH or hemangioma? We said everything which have got an uptake and have no contrast or less contrast in the future is malignant. So we can exclude the FNH, you can exclude the hemangioma and the liver cyst. So either it is a liver mets or an HCC. But if the woman had got breast cancer, probably it's mets. Yeah? If you experience this contrast, you know the washout was very fast, then we know that's liver mets. If it will wash out much later, it will be HCC. But you see, the plane, that's important, match perfectly. And sometimes it's very tricky to find tiny lesions which they describe in the CT, sub-centimeter lesion, tell us what kind of lesion it is. Then you have to scan a half hour to find this lesion, and at the end of your examination, they said, are you sure that you have seen the correct lesion? But by fusion, you know exactly what are the target lesion, and the other doctor, which sent to you the patient, see, okay, he has really done this lesion and nothing else. You see uptake and later washout. Unfortunately, small liver mets. This patient had got breast cancer. She underwent surgery and radiation therapy. So she received 5 years later also CT, where unclear lesion was detected. Again, the patient come back to ultrasound. Every time when we do fusion, we speak about, in the most time, very tiny lesion. That's the most challenging lesion. You see, there is a very, very tiny lesion here. And this is the lesion also in grayscale. What color does this lesion has got in grayscale? Is it gray, is it black, or is it white? Yeah, on the right, here, where the blue circle is, where the mouse cursor is.
It's black in the midfield.
Black, that's very good. Black mean in the most time liquid in ultrasound. So, high suspicion of a cystic lesion. So, we inject contrast. What is here? Is it still black? Yes. If it's still black also here?
Yeah.
Yeah. Remember, we have got a blood pool contrast agent. So our contrast agent is only going to lesion which is alive. A cyst is not alive, it has liquid inside. So that's the reason why it's black. So probably you will make the correct diagnosis, I'm absolutely sure. Yeah, you got it. So maybe you could change your study to biomedicine. So yeah. Yeah. Okay. We got the cyst, and the reason why it's a cyst, because over the whole examination time you see no uptake inside cystic lesion. Another patient, the patient has got cancer of the pancreas, 2014, and the MRI suspicion of liver mets. We should rule out is really liver mets or something else. Here it is very difficult to see. There's a lesion with a marker. There's a lesion in ultrasound. What color does this lesion has got in ultrasound? Yeah, and in the center?
Gray. No, black.
Black, okay. So we go on the next step to the color Doppler. Color Doppler show you where is flow. It's red. Where flow. Did you see any red areas here inside? No. Oh, it's black. So, either the technique is not good enough to show flow, or there is no flow. So in the next step, we go to the contrast. You see there's a marker, there's a lesion, and you still see in the follow-up, it is dark, or even a lesion without any uptake will be what kind of lesion?
Without
No uptake, no contrast inside.
no contrast. It starts with a contrast and then there's no contrast.
No, no contrast during the whole examination, so not alive.
This is cyst.
Cyst. Yeah, you got it. So, probably it's a cyst, and the answer is absolutely correct. You see, from the beginning it's dark, and also in the late phase it's dark, not alive, no contrast inside, no liver mets. In the CT, they described suspicion of a hepatocellular carcinoma, and the patient was sent to us. You see the CT information, you see the blue circle. The circle is also transferred either to grayscale and color Doppler. This lesion has got a diameter around about 1 centimeter. Now we go to the contrast. Contrast arrived. You see very nice this white spot where the blue circle is. And if you look later, in this area, it's getting darker. Okay. Now, a lesion which have got an uptake and getting dark is what? Malignant or benign?
When it changes contrast.
Yeah.
It's
50-50 chance. It's very easy. Malignant. Yeah. So we can exclude the FNH, we can exclude the hemangioma, we can exclude the cyst. The washout was very late, that's the reason why it's an HCC. So, you see, strong uptake. You see this white ball there inside where the blue circle is. And later, wash out of this lesion, late wash out, so HCC. This is after 4 minutes, so quite a long time. Now you see a long patient history. Patient suffered from pancreas cancer. This patient underwent partial resection of the liver. Segment 2 and 3 is part of the left liver lobe. There was a 3 centimeter liver mets. Patient come to the MRI, and in 2021, it's even a long time, 8 years for pancreas cancer, suspicion of new liver mets. You see very nice, in the MRI there's a lesion here, which show a strong uptake, and later it seems to be dark. So if you only have these 2 images in the MRI, your diagnosis will be mets. So you see, we use the MRI for fusion. We see there's a lesion. It doesn't look like really a solid lesion. And look here. We could see a lot of flow. You see this blue and red areas? This is very atypical because if you have a small met, you see only very tiny vessels, not such big one. So something is wrong. But you see in the MRI, the registration was fine, exactly there. So we inject contrast. Take a little bit. There's a marker. And now you see this lesion is filled with contrast. You see? There. Take quite a long time, or? And if you look later, still filled with contrast. So, could it be cancer if it's still filled with contrast?
It's benign.
Benign. Okay. But it will be too easy because you have now the 10th case, you need more training. Is it an FNH? FNH, remember, was very, very fast. Remember? No, it was not so fast. Hemangioma, perinodal enhancement and growing over time slowly? No. HCC, strong uptake, wash out? No, it was filled with contrast. So you can also exclude liver mets. This patient has got a small AV shunt.
What's in it?
Arterial-ventricular connection between the arterial and the vein. That's the reason why it shows a strong uptake in the MRI, and when there's no contrast anymore, it's dark. So they make the wrong diagnosis. But with this help, we can say no cancer, was just malformation. You never see normally these very strong vessels in the peripheral of the liver, except you have got a pseudoaneurysm or AV malformation. Patient with unclear renal lesion come to the follow-up examination. You see there's a very tiny lesion detected in CT, and this marker is transferred to the ultrasound image. There it is. In the next step, we just magnify it. What color is it? It's black. That's good. It tells you probably liquid. Huh? And now we have to prove whether it's really liquid or something else. If it will be liquid, no uptake, because we have got a blood supply. You see, there is a lesion. Is it still black inside, just adjacent to the stuff? Yes. Okay. This means also we can make the diagnosis very fast. Renal cell cancer have got blood supply, could not be, or angiomyolipoma, a benign liver lesion, will also have blood supply. An AV malformation or has also blood supply. The best answer, of course, will be cyst. And you see, this is a small, tiny kidney cyst. No cancer, no need for treatment. Another case. Unclear renal lesion detected in the MRI. Patient come to follow up. I show you the conventional grayscale and color Doppler. So we see there is a big lesion on the right kidney. Color Doppler could not show any vascularization. Now the key question is color Doppler not good enough to show vascularization? Or is there no vascularization? That's the reason why we don't see any color. Okay. You see, this is the MRI. We've got side by side. And it seems to be a complex case because the lesion is big and they could not find the solution. So we inject contrast. There's our MRI lesion. There's our ultrasound lesion. What it is? What would be your best diagnosis? Alive or not alive?
Alive. Not it's black. So not.
Vincent, you have to help.
You said live.
Alive, that means blood uptake or not blood uptake?
We have uptake around.
Yeah, but inside. It's dark.
It's not visible. Right?
Yeah, but if you wait a little bit longer, it's a tricky case. You see here, bubbles, you see there? And also here, there, it's alive. This is a renal cell cancer, and most of the cancer have necrotic changes. That's the reason why most of them is black and not white in the contrast. That's the reason why they had also so much problems in the MRI. So papillary cancer, of course, this have to be removed. So you could say cystic lesion, no. Renal cell cancer, maybe, yeah. Angiomyolipoma are normally very bright, white, will not fit. And AV fistula, strong uptake. So the only answer which could be correct will be renal cell cancer. And you see papillary cancer, and the success is, if we wait, you see there's uptake. This is too much. And also here, there are bubbles moving inside. So, have to be removed. Also here, CT detected a small lesion. There is a small lesion also seen in the grayscale or color Doppler. Even here, we could not see flow. In CT, they describe is it maybe a hemorrhage cyst or what it is. So you see, there's a lesion in CT, there's a lesion in ultrasound. Is this lesion black or gray? Gray. So it's not really liquid inside. So we could not see a flow inside. So we start to inject contrast. Look at this lesion, vascularization inside. And if we wait a little bit longer, you still see this lesion has a washout. It's alive. Also, in this case, it was cancer. So, cystic lesion, we know, must be black. Renal cell cancer will fit. Angioplasty will be bright. AV fistula have got different behavior. So, the only correct answer could be renal cell cancer. And again, you see it. There is the uptake. There's the lesion seen in CT. Interesting case. Bosniak was a radiologist which drew classification of kidney cyst. Bosniak 1 is just a simple cyst. Bosniak 2 has some tiny septs. Afterwards, he makes a decision between Bosniak 2 and Bosniak 3. There's a gap. That's the reason why he brings Bosniak 2F, mean just follow up, F follow up. Then we have got Bosniak 3. If you write Bosniak 3, the risk of having cancer is 50%. So every patient in your report which have got Bosniak 3 will go under surgery. And Bosniak 4 is a cystic solid lesion. So CT, they describe Bosniak 2F. This just need to follow up. So we got the cystic lesion in the ultrasound and the cystic lesion in CT. And look how much more do you see. Look, we have got one sept here. But you see plenty of septs here, which are not visible here. Look here side by side. There's one sept you see in CT, but here are hundreds of septs inside. And look, they have got a strong uptake. Very thick and very strong. This will not fit with Bosniak 2F. This is Bosniak 3 already. So this patient have to go under surgery. And look how much more information you see and how much information you lose in CT. When we switch, you see there's a sept. And if you look at CT data, it's not so good visible. So in this case, of course, it will be not Bosniak 2F, it will be Bosniak 3 because the septs are too thick and too strong for the uptake. Again, summarize the information, strong uptake, thickness of the septs. This is typical for Bosniak 3 cystic lesion. Another patient, uncleared cystic lesion detected in CT, just a follow-up because ultrasound is perfect with cystic lesion. This is a lesion seen in CT, there. There's a lesion seen in ultrasound. If you look very carefully and if you have experience, you see the patient still have a nephrosis inside, so the collecting system is enlarged. Something compressed it. color Doppler could not see a flow. So we inject contrast. There's our lesion. And look at this area. Is there uptake or not? Here, white. Oh? This area is dark, but this is white. So this lesion is alive. We can say also, due to the fact that an uptake it is renal cell cancer, not a cyst, not a benign lesion. Again, also here, this was a papillary cancer in this case. Another renal lesion detected by CT. Follow-up examination was recommended by ultrasound. Now we have got two pathologies. We have got one area which is here. Which color does this area have got? Is it black or gray? Black, perfect. But there's a second area here. Which color has got this? Gray. That means two different lesions. Okay? This is a lesion seen in CT, this one here, and this is the other one. So we look for vascularization. This already shows you some vascularization because you see there are some red dots inside. It must be something which is alive. This lesion is dark or black. Then we inject contrast. You see this lesion shows a strong uptake. This lesion just adjacent is dark. This lesion shows washout. This area is dark. So this will be, of course, also renal cell cancer and a cystic lesion, two lesions. But it's not a hemorrhage cyst which is seen. It's uptake, it means it's alive. Hemorrhage, renal cell cancer. See, very nice there. There's a cyst. This is a black one. But here is a strong uptake. And here you see also getting darker in comparison to the rest of the kidney. So, of course, mix between renal cell cancer and cyst have to be removed. So, I will summarize it. The main option for fusion is tiny lesion to compare. You can also use fusion for intervention, but this is a different topic. Yeah? Very low cost because you can use it on your ultrasound system, and you could use the advantage from CT, MRI and combine it with your dynamic examination. And of course, we don't have any radiation and no nephrotoxic contrast agent. Big advantage. So my last slide, of course, I like to welcome you because you do a really fantastic job in Munich. And if you need more training cases, you can use the QR code. We have more than 900 training cases available. Any questions? You are get really personally trained and.
Well, I do have a question because it looks so obvious that it works to compare images, and so the basic of fusion imaging,
Yeah.
compare imaging to make your diagnosis.
Yeah.
But is it already something that is done in the hospitals?
Yes.
Is it
Yeah.
Because it looks obvious to do that when you're not sure about your diagnosis. You compare it with another.
If available, images are available.
Okay.
That is the hook. Sometimes they don't have images available, but most of the patients have something strange in CT or MRI, and then they come with CT and said, could we match it? Yeah. And with this system, you can do fusion in less than a minute. Really very, very fast.
So this is something that you want to put in the ultrasound machine?
Yes, it's on the ultrasound. All equipment you could see, you could also order it with image fusion. Yeah, all equipment. And you don't even need the high-end system. Also, Philips have migrated from a high-end system to a mid-range system. Yeah, but it's available either for diagnostic, also for intervention.
And this system, there's only advantages. What are the challenges with this kind of technology?
it's not a challenge. It's an additional tool. So you combine two advantages.
Yeah, so it's perfect.
Yes.
Okay.
You just have to do it. That's the only hook. No, you have to start, and once you have done this, it's very fast. For example, prostate fusion. The best technique for detecting prostate cancer is MRI. The problem is, if you do the MRI biopsy, it's very time-consuming and it's expensive. But if you use the advantage of fusion, then you have your MRI prostate on the right side. On the left side, the real-time ultrasound. You mark this lesion, the mark is on ultrasound, and then you can puncture directly on ultrasound with the help of MRI where you see where the lesion is. Because around about 30% of all prostate cancer are not visible in grayscale. They have the same grayscale. But with the marker, you know, even if you don't see it, you just bring your needle to the marker and then you got it.
So with fusion, you can take the benefits of each modality.
Yeah.
You can take the advantage, for example, of CT, MR for, let me say, tissue mapping,
Yeah.
and then using ultrasound for a live
Yeah.
ultrasound imaging. This is also one of the key benefits, having something static and something live just to overlay contrast information or color information. I think this is a very fantastic opportunity.
It's brilliant.
Okay.
Well, thank you very much.
So,
Thank you.
have a great day and enjoy the rest of the conference. You have to stay until tomorrow or you will stay?
I will be there tomorrow.
Yeah, good. Okay, bye-bye.